Great, thank you very much. I'm really so happy to be here. This is my first conference or non-conference trip out of Kuwait over the last 2 years. It's a strange feeling. I'm sure it's the same with many of you. I think I've hugged more people today than I did over the last 2 years. It's always been hugging from far. But on a more serious note, as a president-elect of the Gulf Heart Association, and as one of the people who encouraged the creation of the Gulf Interventional Society, it came up by some of our colleagues, and at the Gulf Heart Association, we supported that. And I'm so happy to see that this regional conference has shaped up the way it has been for the last 2 years. And despite the COVID, I've seen really nice attendance. And for that, I'd like to congratulate Dr. Fawaz and his colleagues for the great job that they've done, truly. So, congratulations and job well done. And I'm sure this conference will grow bigger. And I'd like to thank one more person, Musa Akbar, who is the chairman of the organizing committee and put me in the last 10 minutes of the conference day. So thank you very much, Musa. It's always nice to be part of this game, whether you're in the middle, the beginning, or the end. And on that note, I'll start my presentation. And basically, I'm a person who's been doing a lot of registries, and we did this with a lot of our colleagues in the region. And we know that randomized controlled trials are the reference standard for comparing efficacy and safety of certain interventions, treatment against over another intervention. However, randomized controlled trials are always done in a relatively restricted environment, controlled factors, and it's not representative of the real world population. And therefore, we as clinicians always look at real world studies, and they exist in several formats. And they've been very popular over the last few years with big publications out of these real world studies that come in the form of patient registries, claims database, electronic health records, and patient surveys. And the way you can look at it is that they usually complement randomized controlled trials. What is usually the purpose of these world or real world studies is, I'm sure you've participated in some of those, and whether it's measurements of outcomes or quality measurements that one does in their own hospital or institution, safety surveillance, benchmarking, determination of guideline adherence. This is something we always worry about. Are we really following guidelines, or are we doing things according to our wills? And of course, identifying gaps and deficiencies in one's practice, and so on. However, for these real-world studies to happen, to take place, there are a few things that one have to ensure. You have to ensure high-quality data. And this is mainly through data source verification. You make sure that the data that was entered actually matches what was happening. Provide data access to people, and of course, always protect patient privacy. And one of these real-world studies is patient registries. Usually they take the shape of non-interventional, observational cohort studies. Best that they be prospective, data collection in a real-world setting. They should have a predefined purpose, and management and treatment usually is determined by people who are providing the care, physician and the patients, and there is no protocol that mandates how you practice or how you treat, and that's the idea of it. And it hugely allows you to enroll more patients, more diverse population, because you will not have restricted inclusion criteria. And of course, it does not guarantee that patient groups would be similar, but you hope that you can adjust for the differences when the analysis comes. And as far as our presentation, which is primary PCI compared to pharmacoinvasive, and this was from a registry that we conducted recently, but I'd like to start with this. We don't argue that primary PCI is superior to thrombolytic therapy when it comes to ST elevation and MI management, and this is established long time ago. However, pharmacoinvasive is not the same as thrombolytic therapy. Pharmacoinvasive is when you give thrombolysis with a plan to undergo cardiac catheterization, usually within 24 hours. So it's not primary PCI against fibrinolysis, but primary PCI against pharmacoinvasive therapy. And as a matter of fact, I think this was from 2013 or 2014 in the STREAM trial that was conducted in Canada. The pharmacoinvasive therapy proved effective compared to primary PCI in those centers where it was conducted. And we carried out our own registry in 2016 and 2017, and later published it. And this was Reperfuse Kuwait, where we prospectively looked at the practice in certain hospitals compared to others, and we looked at the pharmacoinvasive compared to primary PCI. And as you can see from the figure, in the composite of mortality, major bleeding, and stroke, there was really no advantage of one over the other. They were both effective and safe, and this is the 1-year mortality and MACE in primary PCI compared to pharmacoinvasive in Reperfuse Kuwait. Again, you look at the composite endpoint and the individual endpoints, there was no advantage, and this was a registry. So, as I said earlier, we've done a lot of registries over the years, and these are some of them from Kuwait, the majority involving entire Gulf, Gulf Care, Gulf Safe, Gulf Race, Gulf Coast, and some from Saudi Arabia. Some are intervention, some are atrial fibrillation and ICD, and the most recent one was the Kuwait CLAP. So what was the Kuwait CLAP sort of advantage in terms of practice that is different from things that we've done in the past? So this was across Kuwait with all comers to the cath lab, whether they're acute or cold. It was prospective, 1-year duration, started towards the end of February 2020. And as soon as we started, COVID hit. And so you can observe through the registry actually what happened to the practice of interventional cardiology. And we collected data for 1 year to February 2021 with 1-month follow-up. Maybe unique about it is that it involves 2 hospitals in Kuwait, 2 large hospitals with many operators and different practice. And the main thing about the different practice is that one of the hospitals does not have in-house bypass surgery, in-house cardiac surgery. So you have a hospital with in-house cardiac surgery, and then another very busy hospital without in-house cardiac surgery. And of course, online data entry with a very deliberate case report form. And This is just a brief, this is the one hospital, Mubarak Al-Kabir Hospital, where we started cathing in April of 2019. So like almost 10 months prior to the registry start. And this is how busy it is. At the start, in the middle of April, till the end of December of 2019, we had done about 600 PCI cases. And then you can see the ups and downs as the COVID hit, and April and June of last year, how the numbers went down. And now the numbers are creeping up. I think towards the end of this year, in a busy hospital like Mubarak, we will probably do 1,200 PCI cases. We would have achieved 1,200 PCI cases a year. So this is in a center that has dialysis patient, has vascular surgery patients, so very sick patients, and we do not have in-house cardiac surgery. So we compared in this one year, we compared those who underwent primary PCI compared to the pharmacoinvasive therapy. And as you can see, there are differences. If you're going to look at registries, there will be differences. Some age difference, Killip class difference, which is worse actually in the pharmacoinvasive group. The LVEF was a bit higher in the pharmacoinvasive group, and more prior MIs in the pharmacoinvasive group, and a lower blood pressure in the pharmacoinvasive group. So this is inherent. You're going to have differences between the groups. As far as the medications that were received, high use, of course, this is in the first 24 hours of aspirin, more clopidogrel in the pharmacoinvasive, which makes sense, and more ticagrelol in the primary PCI group. Same as anticoagulants and inotropes. In terms of procedural characteristics, there were more radial access in the pharmacoinvasive. It seems that with the primary PCI, some of our colleagues, like to go for the femoral access. And there was more staged PCI in the primary PCI group. As far as looking at ECG to lysis time, it was a median of 15 minutes. And the ECG to wire crossing time is 50 minutes. And these are the times that we can record in our registry. We concentrated on when they got their first ECG in the hospital usually. And I think that's a reasonable timing as far as guidelines are concerned for both lytic and primary PCI. And we're looking at the in-hospital outcomes for the different outcomes of angina, recurrent MI, shock, and so on, heart failure, in-hospital, CVA, were similar between the two groups, and looking at other events like AF, VT, requirement for mechanical ventilation. There was really no significant difference between the groups, and acute stent thrombosis as well. And these are in-hospital outcomes. Length of hospital stay was the same, with a median of 2 days in both groups. And the survival at discharge was 98 and 99% prospectively, with no difference. At 1 month follow-up, we had only few patients lost to follow-up, and the mortality rate was the same between the two groups, and the rehospitalization during the 1 month for different reasons, ACS, LVF, PCI, and stroke, was similar rates between the two groups. And in conclusion, ladies and gentlemen, real-world studies. Okay, so I took too long. putting me in the last spot and cutting me off the screen.
Can you bring the last
No,
slide,
it's
last
okay.
slide back, please?
No, so basically real-world studies are one way of complementing randomized control trials. They're an important tool in examining our practice and if there's any deficiencies and how we can improve on them. And we've demonstrated its effectiveness and safety in unselected STEMI population in real-world practice in Kuwait. Within the next month or so, we'll be starting a primary PCI registry across Kuwait, and this will basically complement whatever work and data we have collected. So thank you very much. Thank you for giving me this opportunity. Marة ثانية, congratulations on a great job done.
Thank you very much. Excellent.